So we're going to end this set of videos by talking about the cross-sectional anatomy of the spine, and we'll also be looking at some MR imaging of the spine as well. So first off, just to remind you of the appearance of the cervical spine when we look at that on cross-sectional views. Remember the various unique structures that are associated with the cervical spine. So you can see obviously the transverse foramina with the vertebral artery. You can see the vertebral body, the spinal cord, which you will not see on CT. You'll only be able to appreciate that on MR. And then here you can see the bifid spinous process as well, along with the spinal nerve forming, which again is going to be appreciated on MRI, not so much on CT. And remember that the C1 vertebra does not have a vertebral body. So instead you're going to see just the anterior vertebral arch along with the dens when you're looking at the region where you'd normally expect to see the vertebral body on C1. So here we're looking at a normal cross-sectional view of a CT scan starting right at the base of the occiput. So you can see right here the skull base. So this is going to be the occipital condyles located right here. And then as we descend, you're going to start seeing the atlas. So you can see the C1 with the dens located just posterior to it. So you can see the pre-dens space like we talked about in previous videos. Up here, you're looking at the nasopharynx. And then as we descend here, you can see the anterior arch of C1. You can still see the dens here anteriorly. And then remember that the transverse ligament of the atlas is going to be located posterior to the dens, wrapping from one side to the other across the lateral masses of C2, or sorry, of C1, excuse me, of C1. So it's going to be of the atlas. And then here we can see the transverse foramina, which again, you can appreciate here how you really aren't able to make out clearly, at least, the vertebral artery. If you look really close, you can kind of make out the wall of it, but again, it's not obvious on a CT scan like this. You can also see up here some dental implants causing diffraction of the x-ray beams. And then back here, you can appreciate now the posterior arch of C2, sorry, of C1 rather. We're moving down towards C2. So again, here you can still see the dens in the midline. So we're coming down. We're going to see more of the C2 vertebra. So here you have a good view of the rest of C2. And then as we're descending, you'll notice up here in now in the oral pharynx, we're seeing the epiglottis at this point. So that half moon shaped structure right there represents the epiglottis. We're still seeing the body of C2. We're moving down now. Here you're starting to see the hyoid bone. And then now we see the body of the C3 vertebra, transverse foramina, and then you can see the spinal canal right here as well, or the vertebral canal. As we keep descending, you can see appreciate the bifid spinous process, as well as you can also make out the laminae over here on either side. Okay, and so now looking at a sagittal MRI. So this is a T2 MRI. Remember, these are primarily used for diagnosing pathology. So T1 is really good for anatomy. T2 tends to be the preferred sequence used for identifying pathological changes in various structures. So we will see some pathology on here, but note the location of the spine that you're looking at here is going to be the lumbar region. So you can see this sacrum down here. So it's L5, 4, 3, 2, and 1. You can see obviously the vertebral bodies are large and quite obvious. The intervertebral spaces appear white due to the presence of fat that's filling in between the spinal nerve and the vasculature that's passing through the intervertebral passing through the intervertebral foramen. You can also appreciate the IV discs, which the central region, the nucleus pulposus, is imaging with a kind of a light gray type appearance due to the high water content located within the nucleus pulposus due to the glycosaminoglycans that are located there that are comprising the nucleus pulposus. And so we're going to bring our attention down here towards the region of L5, and that's going to be where we'll see some pathology showing up. But as we move, you can now appreciate in this image the thecal sac. So you can see the subarachnoid space appears bright. So that's the CSF that's located in there. That again is going to be white on a T2 sequence. You can also see the fat obviously back here in the subcutaneous tissue that's also appearing light, which is the same whether you're looking at T1 or T2. And then you can see some of the fibers here comprising the cauda equina. So these are therefore going to represent the motor and sensory nerve roots that are descending from the caudal spinal cord down to the respective intervertebral foramina. And then up here, you can still appreciate the spinal cord is located up here. So remember, that's ending right about the L1 vertebral level in adults. And then as we continue descending, you can see the conus medullaris here quite well. And then once again, the intervertebral discs. And you'll note in this image that the obviously the nucleus pulposus is easy to appreciate up here, but then notice in this disc between L4 and L5 that all of a sudden there's this loss of that T2 signal, and that's due to something known as disc desiccation. So disc desiccation is sort of this drying of the nucleus pulposus. And so interestingly, you might think that this disc desiccation would be responsible for a loss of disc height, but it is actually not the cause of it. And instead, the nucleus pulposus volume remains roughly the same with aging, but what happens is you get this weakening of the annulus fibrosus, and so that causes what's called annular bulging, which would be the definition of a bulging disc, and an end plate bowing. And so as a result, that's where you get this loss of the height of the disc, which you can appreciate in both these situations right here, or in each of these discs. So you can see how there's these bulging discs at either one of these levels in between L4, L5, and L5 and S1 in this patient. Okay, so now we're looking at an axial view, an MRI view of the spinal cord. So once again, you can see in this region, this is going to be where the cauda equina is in this patient. So you're looking at a large IV disc. You can see the thecal sac with the dark fibers here representing the nerve roots of the cauda equina. So you get here's kind of an overlay of basically what you're looking at, just to kind of get a sense of where everything is. And so as we descend, again, you can see the thecal sac pointed out. Here you see the vertebral body, and again, the psoas major muscles on either side of that. And then as we descend, you can see the vertebral arch back here, thecal sac with the cauda equina floating within the CSF. Here's the spinous process back here. Again, we're still descending, so now you can see an intervertebral foramen quite clearly right here, with the dark representing the spinal nerve as it's emerging through or traversing the intervertebral foramen. As we continue descending, here's another IV disc. And you'll notice that this one is actually protruding here posteriorly, and then at this point you can see where it's what's called an extruded disc, which we'll talk more about what that means here in a little bit. But that's going to be compressing the cauda equina, or the nerve roots that comprise the cauda equina. And then here, as we continue descending down here, again, you can see another spinal nerve on either side right here. You can kind of follow it into the intervertebral foramen. Okay, so now moving into the definition of herniation. So herniations are divided into one of two categories, either a protrusion or an extrusion. And so it's important to note that herniations are not the same as a bulging disc. So disc bulging is different than disc herniations. So the bulging that we saw previously that we talked about is due to weakening of the annulus fibrosus. This is actually similar in terms of herniations, but the way that the annulus breaks down and the way that the nucleus pulposus is then sticking out from the annulus fibrosus is going to be what dictates whether you're looking at a bulge, protrusion, or an extrusion. So with the protrusion, these are broad-based, so that means the base is usually wider than what the dome is, whereas an extrusion is going to be comprised of two distinct characteristics. Number one, a narrow neck with a wide dome or bulb on the end of it, and then it's also going to typically migrate up or down a couple of from the disc space. So from the intervertebral disc space, it's either you'll see it kind of migrate up and or down from that region. And so that's the definition of an extrusion. So protrusion, broad-based focal, versus extrusion, narrow neck, and then migration. So looking at the normal disc morphology, hopefully we remember that the annulus fibrosus is the outer fibrocartilaginous structure with the Sharpie fibers that are sort of this cartilaginous collagen-based structure, whereas nucleus pulposus, it also contains collagen fibers, but it also has a high amount or a large amount of glycosaminoglycans or GAGs, and that's going to be what allows it to bind large volumes of water. And so here's just an illustration of what the disc looks like. So remember the annulus in the middle, or sorry, the annulus around the outside with the nucleus pulposus in the middle. And then you have these end plates that consist of hyaline cartilage that sort of forms the interface between the bone of the vertebral body and then the fibers, the cartilage or the collagen fibers that consist or that comprise the annulus fibrosus. And so this end plate is very, very narrow, which is important to note. So keep that in mind as we go through this. But it's similar to most other joints of the body where you have a hyaline cartilage at the end of long bones when they're forming joints with other bones. So now looking at disc protrusion. So again, I mentioned before that the base is going to be wider than the dome. So you can see this broad-based appearance of this disc protrusion. It's also with both disc protrusions as well as extrusions, the size of the disc protrusion is going to be usually less than 25%, so less than a quarter of the total circumference of the disc. And that becomes important when we start talking about bulging discs. So here you have the axial view, and then over here we have a sagittal view where you can see how the protruding disc is coming out and staying at the same level as the intervertebral disc itself. So here's a kind of a caricature drawing of this where you have the protruding disc. You can see it just kind of sticking out here. So this is the nucleus pulposus protruding through the annulus and then forming this broad-based protrusion or herniation of the disc. Whereas the disc extrusion, similar to the protrusions, these are typically less than 25% of the disc circumference, but they have a narrow base, so kind of a narrow neck, so to speak, which you can appreciate right here, with a broader or a wider dome than the rest of the herniated material. So keep that in mind. And then here you can appreciate how the extrusion is migrating above and below the intervertebral disc space where that protrusion is coming, or sorry, where that extrusion is coming from. And here we have just an illustration of what that extruded disc looks like with its narrow neck and large dome. And then finally we have something known as disc sequestration. So this is usually a free fragment of disc material that does not actually have a connection with the disc. So this is what it appears in axial versus sagittal views. And here's the caricature or the illustration of that. And then finally, there are what are known as intravertebral herniations or Schmerl nodes. And so Schmerl nodes are quite common, but what happens here is, as the name suggests, the disc material herniates into the vertebral body. And part of that's due to the thin character of the end plates, of the vertebral end plates. So you can see how it's protruding through that end plate and into the substance of the bone. And the role of these end plates in accelerated disc degeneration and also discogenic pain is really not clear at this point. So there's a pretty big disagreement in the literature and amongst researchers in this field as to what the significance of these sorts of Schmerl nodes are. If you have breakdown of the end plate, does that then lead to significant disc degeneration? Does it accelerate that degenerative process? And or does it also cause significant pain? And it's really unclear. But in the series of images, you can see here's an intervertebral disc. You can see the thin end plate, which is better appreciated here in B, where you can see that hyaline cartilage, kind of that pinkish colored staining above and below the disc itself. And you can see the disc itself appears sort of whitish. That's going to represent the nucleus pulposus. So if you look at C, here you can see the disc, and then down here is going to be the hyaline cartilage. So this would be the end plate, the vertebral end plate, and then down here you're moving down into the bone of the vertebra from there. And then up here in D, you can appreciate how the annulus fibrosus, the fibers, the collagen fibers of the annulus fibrosus are continuous with the end plate. So there's a distinct linkage between those two structures. And so we know that this motor end, this end plate, the vertebral end plate, plays a significant role in nutrient absorption or transport up into the annulus. And so that's some of the disagreement there, is what role does that play then in disc degeneration? If you have degeneration of the end plate, does that accelerate the process of disc degeneration? You would think it might, since it plays a significant role in maintaining the health of the disc. But again, there is some disagreement in the field on that. So going back to the composition of the IV disc, the annulus fibrosus is primarily type 1 collagen. The nucleus pulposus primarily type 2 collagen, along with a large amount of glycosaminoglycans. And then you have the hyaline cartilage, which is going to be at the vertebral end plate, whereas there's some fibrocartilage that's on the nucleus pulposus side of the annulus fibrosus. So here we have an example of a large Schmerl node at the superior end plate of L1. So you can see here where the disc is protruding intravertebrally within the substance of the L1 vertebra. So again, these are actually relatively common in individuals. So it's 40 to 75% of autopsies show evidence of Schmerl's nodes. So again, they're very, very common, as is back pain, as is degenerative disc disease. But we still don't understand the exact significance of these Schmerl nodes, because they can be asymptomatic despite the really nasty appearance of these on imaging. So now coming back to the idea of a disc bulge. So remember I mentioned before that this is distinct from a disc herniation. And so a disc bulge is where more than half of the circumference of the disc is protruding out from the disc. And so again, it's distinct from a disc protrusion and extrusion. And so instead, what happens here is the annulus fibrosus is limiting the outward movement of the disc, and so therefore the disc bulge will not extend above or below the margins of the associated vertebrae. Whereas the disc protrusion, as we talked about before, this is going to be confined to the same level as the location of the vertebral disc. It's going to have a broad base, as is shown here, and then it's going to involve less than 25% of the total circumference of the IV disc. And so once again, you can distinguish the protrusion from a disc bulge in that it's less than 25%, so less than half, but it's actually even less than that. So less than 25% of the circumference of the disc is involved. And then you can distinguish a protrusion from an extrusion by looking at the base. And so if it has a wide base, you know that has to be a protrusion and not an extrusion. And then here's the example of a disc extrusion, where you can see that narrow base, the narrow neck of the herniated disc. And so then you have a wider dome on it. And so again, this is a type of IV disc herniation, but it has a narrow base on it. So you know it's an extrusion versus a protrusion. All right, so now we're looking at going back to this MR sagittal view of the lumbar spine. And again, we're going to be looking at a couple of examples down here, or an example at least of a extruded disc. So at this point, it's hard to tell at this point whether you're looking at an extruded or protruded disc, but it's clearly not just a bulging disc at this point. You can definitely make out the fact that this is a herniated disc. And then again, as we follow this, you'll see that now at this point it's clearly differentiated into an extruded disc at this point, where you can see it obviously compressing the cauda equina. So those nerve roots located there, the motor and or sensory roots, would be compressed, causing significant pathology or symptomology for this patient, almost certainly. And so looking at how a herniated disc might affect the patient, it's important to keep in mind that it could either damage the fibers that are exiting at the level where the protruding disc is located, and that's going to be more of a lateral herniation that's occurring in that case. So in this case, you have L3, L4 with the L3 disc. If it's coming out here laterally into the intervertebral foramen, it's going to compress the L3 nerve root, and so that's going to cause issues with the L3 root, probably a radiculopathy in that case. whereas it could also affect the L4 or even frankly the L5 nerve roots. The L4 would be more likely with like a posterior lateral extrusion or protrusion, so a herniated disc that's more in the posterior lateral compartment is going to affect usually the lower nerve root, so below the level of the herniation. The cauda equina itself can be more broadly affected as well, and so in this case, this would cause what's known as cauda equina syndrome. And so this can cause weakness in the lower extremities as well as saddle anesthesia, so in the region of the perineum. And then commonly you'll also see urinary retention in these patients. So when you get this protruding or extruding disc posteriorly, if it herniates far enough, eventually it can start compressing some of these nerve roots. Keep in mind that this is really the sort of the so-called safest disc herniation that can occur, because obviously you have this large space back here, this large lumbar cistern, which is not going to be easily compressed by a herniated disc unless it's herniating a very far distance into that thecal sac, in which case then it can eventually start compressing some of these nerve roots. And the exact roots that'll be affected just really depends on the exact location of the herniated disc. But but below wherever the fibers are being compressed, it's going to affect everything below that. So here we have a focal disc protrusion. Again, you can appreciate the wide base on this. So it's a protrusion as opposed to an extrusion. In this case, it's compressing the S1 nerve root. We can also have as I mentioned before, with a lateral herniation that can compress a single nerve root as it's emerging through its intervertebral foramen, and so that can. The other causes of that include local inflammation, but in this case, this causes what's known as radiculopathy, which is usually a radicular type pain with shooting pain going down along the course of that nerve, as well as potentially paresthesias. Here we have another example of a disc herniation. In this case, it's a disc extrusion. So you can see how it has a narrower base relative to the dome of the herniation. And in this case, it's also compressing the right S1 nerve root. Here's another example of a sort of an interesting pathology known as annular fissures. So this is a degenerative deficiency of one or more of the layers that make up the annulus fibrosus. And so although there's different terms for this, the preferred terminology is annular fissure over annular tear. So it's the same basic idea, but effectively what happens here is the annulus fibrosus is breaking down. So there's a degenerative process that's affecting the annulus, and so you can see that pointed out here on these two sagittal views. And so the reason that we don't typically use annular tear as the proper terminology is because that indicates that there's some sort of injury that's caused this, but usually it's not a specific injury that's the pathogenic mechanism behind this type of pathology. Instead, it's some sort of pathophysiologic process that's causing pathologic breakdown of these fibers. Here we have a cervical sagittal MRI scan. So we're going to be looking at, I'll give you a second to look at it here and see if you can identify where the issue is. There's actually a couple of them in this image, but you'll note if you look at the sort of the anterior aspect of the thecal sac, so the dura, or the posterior vertebral line back here, you'll see that it's not really forming a smooth line. You see these sort of bumps here, and so especially up here, you can see an especially large disc herniation that's present there. You can see sort of a small one right here and another one down here. And so if we go to the next image now, you can see this extremely large disc extrusion. So you can see how it's going above and below the vertebrae, above and below the location of the intervertebral disc. And so this is causing a massive extrusion at the C5-6 intervertebral space, and this is going to cause a myelopathy in this patient. So myelopathy just indicates a spinal cord defect. And so with a myelopathy, what we expect to have below that, at and below that level, includes weakness. So this would not only affect the upper extremities at C5-6, but also the lower extremities. It's going to cause potentially sensory loss, as well as the specific type of weakness that we see here is what's called an upper motor neuron type of weakness. So this is a spastic paralysis where the muscles are still working effectively because they still have their lower motor neurons innervating them, but the upper motor neurons aren't able to properly communicate with those lower motor neurons to control them based on the way that you want to move. And so therefore we call that a spastic paralysis, where reflexes are increased and you have this sort of muscle rigidity associated with it as well. All right, and then this is coming back to something that we looked at previously, but this is the end of the spine lecture series here. But you'll notice that here, if you look at the Bayesian relative to the DENS, in this case, you have obviously an increased distance between those two structures. Also, the posterior the Bayesian axial line is also increased, and so this indicates a atlantoaxial dislocation injury in this patient. So that's the end of this lecture, and so now we'll be moving into the extremities in future ones.